Down syndrome.
Okay, Assalamualaikum warahmatullahi wabarakatuh. Okay, first of all, I have to admit the slides has not been prepared by myself, so it's last night. Okay, because I didn't have time. Because too many assignment. Anyway, so let me just share the presentation. Okay, let's see. Okay, this is very good slides. I think the content of the slides is adequate for yourself. But I'm going to maybe stress upon some important facts that you need to know that is relevant for your level and for your studies. Okay, anyway, so I'll start my presentation with credit to Dr. Nadira, my MO, for preparing the slides. So introduction, so basically Down syndrome. Remember, Down syndrome is a chromosomal anomaly. Okay, remember, when we talk about genetic, there's a few different type of genetic anomaly or genetic abnormality or genetic defects. It can be at macro level. Okay, macro level, these are the mutation or the abnormality can be detected by conventional karyotyping. So when we talk about genetic, you need to know where is the lesion or where is the defect. Okay, at where is the point of defect? That's number one. When is the defect occurred? Okay, the mode of inheritance, is it Mendelian or non-Mendelian inheritance? And then you need to know, and then you need to also know some of the risk factors and investigation. Okay, not all investigation is suitable for all type of genetic defect. Okay, Down syndrome being a chromosomal defect, okay, which means the defect occur at the chromosome level. So it's very large. We are talking about a large numbers of genes affected. Okay, and therefore the presentation are quite global, which means it will affect more than one system. At least usually most of the system will be affected. Okay, so because it is a large defect, okay, involving the chromosome, so conventional karyotyping can diagnose Down syndrome. Okay, you can diagnose Down syndrome by using conventional karyotyping. So remember, so investigation to Down syndrome is karyotyping. Okay, on top of that, you can also use FISH, apa tu? Fluorescent FISH, immunohybridization. I can't remember lah. Immunofluorescent hybridization. I can't remember. So basically FISH lah. You can use FISH. Apa dia? Yes, fluorescent in situ hybridization. So FISH, you can use FISH to diagnose Down syndrome. It's more, we call it targeted. Okay, it's more targeted. But otherwise, it's karyotyping sufficient. So it's the most common chromosomal abnormality among life-born infant. Okay, what happened when I say it's chromosomal means either the chromosome deleted, the whole chromosome deleted, or it's edited, or it's duplicated or abrated. So the chromosome is affected. But remember, it may not necessarily the whole chromosome, but at least half or a large part of the chromosome is affected. Because sometimes Down syndrome is caused by, for example, translocation. It's not the whole chromosome is translocated. Maybe major part of the chromosome is translocated, but it can also produce Down syndrome. Okay, so it is the most common chromosome abnormality among life-born infant. It is the most frequent form of intellectual disability caused by microscopically demonstrable chromosome aberration. Okay, so it is a trisomy chromosome. So it's trisomy trisomy because chromosome number 21. So trisomy 21. Okay, the adenine. There is three. Okay, basically in general, when we talk about trisomy, there are few. You can divide chromosomal abnormality. In general, you can divide into whether it's involved the sex chromosome or it involved the what do you call it? Saya boleh lupa sebenarnya. Mesti non-sex chromosome. What do you call it now? I don't know, puasa I lupa lah semua benda. Anyway, it's either involve sex chromosome ataupun non-sex chromosome lah. So in general, you have to understand we've got 23 pairs of chromosome. So sex chromosome being the 20. Okay, number one, trisomy involving the most common the non-sex chromosome is the 1 to 22. But the most Edward 18, patau notice period. Edward, some can live up to teenagers or so they can live up to the adulthood and even old age up to 50, 60. Okay, and the most common cause of death that shorten their lifespan is actually metabolic problem. Because in general, Down syndrome, what happen is they age advanced than their physical age is much advanced than their chronological age. People with at the age of 10, Down syndrome people is their physical is equal to so there are markers that can suggest presence of Down syndrome in the fetal. For example, like the HCG, beta HCG, AFP, and also the nuclear thickening by scan and sort of and so on. And the diagnosis can be done by CVS, for example, or amniocentesis. It depends on the age of the conception of the pregnancy. So itu you boleh tanya Wenji lah. Okay. Okay. Okay, this is a bit too complicated. Okay, dysmorphic features. This has to be remembered. When you see a Down syndrome, when you've got a Down syndrome cases, you have to imagine the Down syndrome from top to bottom. Okay, when you approach, like physical findings or dysmorphic features, you have to be listed down from top to bottom so that you won't miss. Okay, from the top, from the top we've got the head kan, the head. So they've got flat occiput, for example, they've got flat occiput. And then they've got microcephaly. Usually they've got quite microcephaly lah, but it's not something that is universal. But they can get microcephaly, flat occiput, and then intellectual disability is something that is global lah in Down syndrome. Even the mosaic Down syndrome, usually the intellectual is also slightly affected, can be affected. They rarely have normal intellectual. Oh, I forgot to tell you about the type of Down syndrome. Okay, Down syndrome can be obtained or can be the defect in Down syndrome, the trisomy 21. Okay, can rise from 3 different incidents that occur during pre-pregnancy or during the conception, or actually during the development of the gametes. Okay, so there's 3 type. 3 type you can the defect can be either mosaicism. Okay, you can have a mosaic Down syndrome that resulted from the defect occur quite late after the conception. Okay, if the genetic defect occur after conception during the mitosis, during the cell division, during the embryological development, then it can give rise to Down syndrome baby with disproportionate number of cells with Down syndrome. Understand kan? That's mosaicism. So remember, so in mosaicism, the degree of severity depends on the proportion of cell with trisomies 21. Okay, for example, if you've got like 50-50, which is 50% of the cell are trisomies, another 50% are normal, then you may get like half of the severity. But if you've got I've got patients with like 20%, 30% of trisomies, which are quite well. They've got some features. Usually, the physical features are there, but the internal organ are usually spared from Down syndrome. And then they may have a better intellectuality and so on. That's number 1. But the most common is the non-disjunction. Okay, non-disjunction occur during the meiosis. Okay, during the development of gamete, the production of gamete. So during the meiosis, what happens is there's a disproportionate division of the chromosome 21. So one of the gamete get 2 21 chromosomes, but another one got 0. So it ends up woman. If the mutation occur, if the defect occur during meiosis, so a woman may have like gametes with 2 chromosomes or gametes with no 21 chromosomes. So it can if you only got like if a fetus only got 1 chromosome 21, it is incompatible with life. So usually it leads to abortion. But if they receive 2, if the gamete receive 2 chromosome 21, and later on during conception, a sperm with a normal 1 chromosome 21 merge, they will get trisomy 21, which is Down syndrome. Okay, but the second one is the translocation. Translocation means the chromosome 21, okay, attached to another chromosome. So when the cell division occurs, especially when the production of gamete during meiosis, okay, what happens is a gamete may get 121 chromosome that is isolated, that is discrete chromosome 21, while the other chromosome 21 fuse with other chromosome. Okay, this is what we call translocation. So it can be a Robertsonian, or it can be just non-Robertsonian translocation, which means maybe it can be 21 to 21, means the two 21 attached together. Okay, that is also called translocation. Or it can be Robertsonian, means 21 attached to other chromosome, usually chromosome number 13, chromosome number 9. This is where it's attached to. Okay, this is another one, causes of translocation. So between the three, the most common is non-disjunction. Remember, non-disjunction is the most common cause of Down syndrome. That's number one. Number two is, second most common is translocation. Number third is mosaicism. So there are features. I mean, there are things in the history that can give you clues on what is the causes. Okay, what is the underlying etiologies. For example, if there's a recurrent of Down syndrome in the family, for example, maybe two siblings with Down syndrome, chances are either the mother or the father are a carrier of stable translocation, which means the father or the mother has two chromosome 21. However, one of the chromosome is attached to another chromosome, so leading to the production of gamete that is unequal number of chromosome 21. So, for example, I've got a family of mine who I know of, who is a carrier of Edward. The father is actually is a we call it stable translocation carrier of Edward. So all the child is Edward lah. So in this kind of case, the risk depending on the type of translocation. If the translocation is, for example, 21 to 21, then all the baby will not be normal. But if the translocation is 21 is Robertsonian, which means 21 to other chromosome, then there is a risk of getting a normal baby. But again, there's high risk of getting Down syndrome or abortion, monosomy 21. Okay, and then if the mom is old age, no family of Down syndrome, then chances are this is non-disjunction. If the presentation is mild, then chances are this is with subtle features of Down syndrome, then most likely this is a mosaicism. But again, the diagnosis are all similar using karyotyping. But you may need to offer screening to parents if the parents have risk factors, for example, very young, and again, multiple Down syndrome in the family. Okay, so these are the features you have to remember this. Okay, from the top, again, learning disability, flat occiput, and then you've got on the eye, you can get epicantic fault, white space eye, low set ears, and usually quite small lah. The ears is slightly small, and then they've got macroglossia, which leads to relative microstoma. The mouth looks a bit small relative to the tongue. Okay, they have short neck. They don't have web neck, but it's a short neck. And then excessive skin at nape of neck. This is the nuchal thickening. Okay, they've got narrow palate, abnormal teeth, and so on lah. Okay, you have to look at from the top to bottom. Okay, the extremities, the fingers, the hand, they've got short, broad hand, trident finger. Susah nak tengok. Tapi it's trident finger lah. And they've got transverse palmar crease. And then they've got clindactyly of the fifth finger. So incurved fifth finger with hypoplastic middle phalanx. And then they've got sandal gap at the lower limb. And then they've got, in general, the Down syndrome baby are quite hypotonia. So they got generalized hypotonia and hypoflexibility of joints. Okay, because of the hypotonia, they tend to get laryngomalacia. Okay, because the muscle globally are affected, so they can get laryngomalacia. It can be due to the muscle or it can be due to the cartilage. Okay, the flexible cartilage. On top of that, they've got delay in development, motor, and also the rest. Okay, the rest, speech, social, and also fine motor, most likely due to the learning disability. But the gross motor will also affected because of the hypotonia. And then because of the hypotonia also, they've got weak smooth muscle, leading to most of the time feeding intolerance. So they got poor sucking at infancy, they may get feeding intolerance and growth problem and so on. Okay. What else? And because of their hypotonia again, they may have poor motor reflex. I think that's all actually. You can read this yourself. Okay, other medical problems that is very important for you to know and that you need to screen is number one is the cardiac defect. Okay, cardiac defect, this is number one morbidity and mortality, causes for mortality in neonates. Being about 30% at least of Down syndrome will have some kind of cardiac problem. The most common is complete VSD, VSD, ASD. It can be anything. It can be anything, but usually they will have one or two. Okay. Sometimes they may be born with complex congenital heart disease as well. Okay. On top of that, they can also have hypothyroidism. Okay, intellectual disability. Sometimes they can have behavior or psychiatric disorder, like autism. But it's not that common actually. And then they've got dementia very young age. Okay, because as I mentioned, they got advanced. Their physical is advanced. The physical age is more advanced than their chronological age by about 10 to 20 years. So by the time they 50, they may already be like, the brain may already be like 70 or 80, and it accelerates exponentially. So they get dementia very early. GI anomalies is very important. Duodenal atresia is quite not uncommon in neonates. Duodenal atresia or stenosis. So duodenal atresia usually can be diagnosed antenatally by the double bubble sign in the fetal scan. Duodenal stenosis, sometimes they can present it with polyhydramnions because they cannot swallow the amniotic fluid. They can get also imperforated anus, esophageal atresia, tracheoesophageal fistula. The GI they can get Hirschsprung disease, celiac disease. I'm not sure actually, but I think Hirschsprung. Endocrine problem is I think about 20% of them will have hypo, more than 20%. About 20 to 30% of them will get hypothyroidism. Okay, this is because of thyroid agenesis. So they don't develop thyroid hormone, thyroid gland. Then they will have obesity, diabetes, and short stature. Okay, short stature, not because of growth hormone deficiency, but rather than the insensitivity. And then they also got obesity and diabetes, and this is the morbidity that kills them. Okay, because most of Down syndrome by age of 30, 40, they will have diabetes, and by age 50, they will have heart problem and they'll die because of heart failure. And about 10% of them will have atlantoaxial instability. This is one of the most important comorbidities after heart problems because it can lead to paraplegia. So sometimes you have to advise them not to do contact sports too much. Okay, they have to do sports because they've got this high risk of metabolic problem. So they have to do sports, but remember not to do too much contact sport like rugby are not advised for them because they've got quite unstable C1 and C2, which can lead to dislocation and paraplegia. OSA is quite common. Being obese and short, they get high risk of OSA, and then respiratory infection. Urologic abnormalities, hypospadias, cryptorchidism, testicular cancer. I'm not sure about this. Kidney malformation sometimes. So female are fertile, but some female are fertile and not all. Some female are fertile and they can get pregnant. So remember, when you club Down syndrome teenage, okay, this is one of the things that you have to discuss with parents about sexual safety, and then hygiene. When they can get period, so how to take care of their hygiene when they've got period, when they've got menses. And then their fertility issue, they can be abused. A lot of Down syndrome abused and they got children. Okay. all male are all male are infertile. So male Down syndrome doesn't is fertile, but is infertile, but female can be fertile, so they have to be protected. Some of them got immunodeficiency and get skin disorder. Okay, leukemia, the lifetime risk is 1 to 1.5%. Leukemia, especially AML. Okay, but Down syndrome with leukemia usually they've got better prognosis, slightly better prognosis than those without leukemia, without Down syndrome, because there are few theory behind it. One of it is because they've got more chromosome in their cells, okay, which make them more responsive to chemotherapy. A lot of chemotherapy they're targeted at the nuclear level, at the DNA level, kan? DNA level, they stop cell division, they affect the cell metabolism. So, for example, PTO, for example, Prophet Tayuricil, itu PTO kan? Tayuricil lah, for example, Tayuricil or what you call it? Contoh asparaginase, apa tu, methotrexate, what else? All this alkylating agent, okay, folic acid inhibitor kan, macam methotrexate. They works during the cell division. So they work at the chromosome. So when the cell has more chromosome, so they require more fuel. You know, like more fuel, like more they need cytarabine versus cytarabine. So they need more uracil, they need more cytarabine, they need more, you know, all this nucleic acid for their cell division. So when we give chemotherapy, which most of the time inhibit the metabolism or prevent the consumption or absorption of these metabolites for cell division. So the cell with more than euploidy, which is the polyploidy, that has more than 23 pairs of chromosome, will be affected the most. Okay. That's why they usually very responding to chemotherapy. However, being immunodeficient and being a lot of them have a lot of comorbids, sometimes they succumb not to the cancer, but they succumb to the treatment. And then visual impairment also very common, like squint, cataract, nystagmus, glaucoma, refractive errors is almost global. Most children with Down syndrome will definitely need glasses. And then hearing loss is very common, and this actually worsen the speech delay, because they inevitably they will have speech delay because of their learning inadequacy or learning disability. On top of that, with the hearing loss, they will have delay in acquisition of speech. So management is very simple. It's a supportive management, expected management. Okay, when we talk about expected management, means we screen for possible comorbids or complication. So babies with Down syndrome have to undergo echocardiogram to screen for any presence of cardiac abnormality. We also have to screen for the thyroid function test at birth and at least at day 72 hours of life onwards, after day 3 or day 5. And also then yearly screening for leukemia and also for hypothyroidism, because hypothyroidism can develop later at life. Okay, we don't routinely do plain or epi cervical X-ray, but in patient with sign of cord compression, you have to do MRI or at least X-ray. Okay, we don't actually confirm the diagnosis by chromosomal analysis, because Down syndrome is diagnosis of by clinician. So we diagnose clinically, but if the mother wish, the parents wish, we can offer genetic testing to confirm. Except for, as I mentioned, some cases we do like offer genetic screening because of the suspected risk factors. The ophthalmology assessment before 6 months old. Hearing assessment is very important. Should be done before the age of 3 months. to detect hearing losses. A lot of them end up with hearing aids. And then EIP, early intervention program, involving the occupational therapies, physiotherapy for physical strengthening, for muscle strengthening, mobility, to encourage development, physical and mental development using occupational therapy, and so on. Support group lah. There's also support group is very important. I think that's all actually. Thank you. Got any questions? I don't know whether this is helpful, but because I think Down syndrome is quite easy. You can just read it. Okay, any questions? Okay, in general, in pediatric, okay, Down syndrome almost certainly will come out in your exam. Either pro ke end of block mesti akan keluar. Okay, almost certain. Either you got it or you don't get it. In the MCQs always can always ada one question about Down syndrome. EMQ maybe akan ada, OBA pun akan ada, definitely akan ada lah. Okay. And then apa tu? Dia punya KFQ pun almost always ada one question on Down syndrome. It's very important topic because we can ask anything. Okay, for example, my interest in Down syndrome is genetic and endocrine, so I will use Down syndrome to deliver my endocrine question or my genetic question. Dr. Taufik can come up with his cardiac question using Down syndrome. Neonates, Down syndrome, a lot of complication. Baby with Down syndrome, they end up with a lot of postnatal complication, be it like PPHN, apa lagi? Feeding intolerance, cardiac problem, heart failure. So they can present at any level of life. Okay, they present to me with endocrine problem, usually at the young age, less than 1-2 years old. And then they're presented again to general pediatrician with leukemia, usually at the age of 3, 4, 5, 6, 7, 8. And then neonates, they present after birth. Cardiac, they usually presented, if not detected at birth, they will be presented at around 6 weeks of life with heart failure, or they presented slightly later at 1 year old with hyperceltic spell and turn out to be TOF. But usually when they've got a cardiac lesion, for example, they go to the extreme. For example, if the VSD is very big VSD, end up failure very early on. If they got TOF, the TOF usually PDA is very small, or PS is very severe PS, requiring intervention very early. Okay, ada soalan lain? Oh, by the way, OSCE memang semua keluar lah. Don't worry about that. Confirm, insyaAllah confirm keluar. Okay guys, ada soalan? Ada soalan tak? Sambar. Sorry, Sambar ni nama ayah awak ke nama awak? Nama awak kan? I remember your name because your name, I suka your name, mesti ada Sambar. Your name Sambar? Is it because ada keturunan apa-apa ke? Oh, so your family name semua Sambar? Sebab ada orang mana ke? I mean, you originally from elsewhere ke? Kelantan? I know one of my friend, dia punya grandfather ke great grandfather dia is